Welcome to Better Sex, where you get the information and inspiration to create and enjoy your best possible sex life. Join your host, sex therapist Jessa Zimmerman, as she brings you expert guests, helpful tips, knowledge, and strategies to improve your intimate relationships. And now, your host, Jessa Zimmerman.
Hey everybody, it's Jessa back for another episode of the Better Sex Podcast. Thank you for your support and your ears, your listening, your participation in this. Speaking of participation, you may have noticed that some of my podcasts feature interviews with just regular people, right? Sharing their personal story. I do those interviews anonymously and sometimes even disguise the voice, so like truly anonymously. But I do them because I think it's really helpful to hear people's stories and to know that you're not alone. So if you, listening to this, would be willing to come on and talk about your sex life, your journey through obstacles or challenges and what you did about that and how it has worked out, at least so far, I think that would make a big impact on people. So I really, I invite you to consider it. I know, you probably don't think about talking about your sex life in such a public forum, but nobody would know it was you. And I would welcome the chance to talk to you about how you have overcome your struggles. So you can always just email me through the Better Sex Podcast website. Get in touch. We can at least just talk about it and I can answer your questions. But I'd love to have you more involved than just your ears if that would work for you. Today's episode is, it's related to topics I've covered before, but we're specifically talking about medical approaches to women's sexual health concerns, sexual struggles. So we've talked about libido issues and desire discrepancy, and we've talked about sexual pain with a therapist before, but my guest today is Dr. Ashley Fuller. She was an OBGYN, but she has dropped the OB part of her practice and really is just focusing on gynecology and women's sexual health. And as she talks about in the episode, even as a gynecologist, she got really limited exposure to treatment of women's sexual concerns in her residency program. So she has gone on to get a lot of additional training and really developed, the toolkit that she needs to be helpful to people. So it just still blows my mind that physicians like this don't get more training in sexual health and certainly in treating sexual concerns. But anyway, she's my guest. She is here to talk about dealing with your doctor about this stuff and what some of the treatment options might be for both low libido and then sexual pain, specifically for women. So that's the episode today. I hope you enjoy it. The Better Sex Podcast is brought to you by the Sex Without Stress online course. It's a course for couples to escape the cycle of disappointment, avoidance, and pressure in your sex life. So if you're in a pretty good relationship, there's a lot of love and goodwill, but sex is your struggle, this could be for you. You work in the privacy of your own home and at your own pace to create a sex life you can both look forward to. If you want to learn more, go to sexwithoutstress.com/program. So Ashley, thank you so much for taking the time to talk to me today.
Yeah, I'm really excited to be here. Thanks for asking me to be part of your podcast.
Yeah, of course. Would you just say just a word about who you are and where you practice and, what's gotten you into working with women's sexual health?
Yeah, so I'm Ashley Fuller. I'm a gynecologist at Swedish GYN Specialists First Hill downtown. And I've been an OBGYN here for about 9 years. And I recently changed my practice into a gynecology-only practice focusing on women's sexual health. I did that because I feel like a lot of women have sexual problems. And I feel like in our residency and in our medical training programs, we as providers did not get a great education about women's sexual health on how to talk to women or treat women with sexual dysfunction. And I feel like in the past, it has left me feeling somewhat ill-prepared to handle some of the things women brought up to me as their complaints, and also left me feeling almost like sense of dread when patients would bring up their low libido because I didn't really feel like I knew how to help them. And I feel like a lot of women feel that way from their, from when they bring these things up, and they sometimes feel brushed off by gynecologists or by the medical profession. And I really wanted to change that and really focus on this as my practice and really try to help women who have sexual concerns because it is super common and it's complex. It takes time and it takes, being dedicated to really trying to make a difference for these patients.
Yeah. It continues to surprise me. You would think, I would think that a gynecologist or a urologist who are specialized, in these body parts would be really prepared to deal with sort of sexual functioning complaints. And that's just really not the case, is it?
Agreed. Yeah. It's shocking how little education we got on this in residency. It's kind of shocking. Even just, I do a lot of vulvar things. I think a lot of gynecologists and people who practice medicine are just taught to kind of move right through the vulva and look right at the vagina.
It's so funny. Like even the language in our culture, right? Nobody uses the word vulva. It's all just sort of lumped as vagina. And medically, you're saying the same thing. It's like the vulva doesn't exist, sort of.
Yeah.
Wow.
But now, every one of my exams, I look at the clitoris and my husband's like, how were you not taught to do that in residency? If it was a man, everybody looks at the penis. And I said, yeah. But it's not what, it's not how we were taught. It didn't seem to be important in our studies, which is so ridiculous. So
yeah, it's really crazy. So were there human sexuality classes in medical school itself, or the only exposure you really got was in residency?
No, we had some human sexuality classes in medical school. Okay. I would just say from a how to treat women's sexual dysfunction standpoint, we had minimal to none of that exposure in residency.
Even as a gynecologist, I don't know much about, right? Because you go through residency as, in the specialty.
Exactly. Yep.
Wow.
Yep.
Okay.
Yeah. And the truth is, these are not easy things to treat. You treat these things too. And until recently, there hasn't been a lot of medication to actually treat it. But at the same time, I think women come to their gynecologist frequently to get their pap smears and do the other, cancer screenings. And we are some of the first line of people that these patients talk to when they have a bad experience with one of us. Yeah. And they're kind of left with this idea of who do I talk to about this?
Yeah. Yeah.
And that makes me sad. So I'm excited to be a resource both to patients, but also people in our community, other providers that are kind of like, I don't know what to do with this patient. I'll send them to Dr. Fuller because I'm getting a lot of that and I love it. It's great.
Yeah. Good. You can get out there and spread the good word.
Yeah.
So, today, I think we're going to talk about two main sexual concerns for women, right? Low libido and then sexual pain. And, I know we can't do an exhaustive, we're not going to cover everything, but let's take those one by one. Let's start with low libido. And I know you sort of separate postmenopausal and premenopausal, right? Libido issues for women.
I do. I tend to think that a lot of women's low libido starts to happen in their mid-40s. And that's kind of when our testosterone levels start naturally going down a couple of years before menopause. And so I think it's common to have a decrease in libido around that time. But I also think that menopausal patients also have their testosterone levels stay fairly stable, but they still can have other reasons to start having low libido too. So in the guidelines on how to address low libido in patients, I do try to kind of separate things. I think the treatments can be different.
Right. And I just want to mention that there are so many non-medical reasons for people to have low libido, right? Like this is what I deal with in my sex therapy practice, relationship issues and stresses, and all kinds of things. It's not like if somebody has low libido, they've necessarily gotten some physical thing wrong with them.
Exactly.
But what are the kinds of physical explanations for low libido? Besides the change in hormones with menopause, what could be going on with somebody that's premenopausal?
A lot of it is the stuff you're saying, like the relationship stuff. It's not always a physical thing.
Right.
So when I ask them, I actually do this decreased sexual desire screener with them. And it actually has a question that goes over all the possible reasons they could be having low libido. And do they have a medical problem that's making it hard for them to have, to be aroused? Are they on a medication like an SSRI for depression? Do they have relationship issues? Do they have other sexual dysfunction like pain with sex, stress, fatigue? These things are, a lot of these are things I would talk about people like you, sex therapists, because a lot of these things are things that can be helped by that, but some of them are physical things. And so pain with sex, hormonal changes, like you mentioned, menopause or recent childbirth. Those are also things that can also be contributing. And sometimes people don't actually have any contributing things when you go through that list. or just kind of like, yeah, I don't have a lot of desire. I haven't had it for a long time, So it's sometimes that list helps me kind of figure out what way to go. Like, should I say you should see a sex therapist, or a therapist to talk about other things, not necessarily just about sex, like underlying depression, or do I go the route of you might need a medication or some hormones? So that kind of helps me decide.
Okay. After childbirth, I mean, obviously there might be the birth trauma or the physical recovery of that process, but what else might be going on physically for somebody that would affect their libido?
Well, I mean, after you have a baby coming through your pelvis, you can have pelvic floor dysfunction that could make you have pain with sex.
Okay.
So sometimes that, I always think we don't ever want to do something that's painful for us.
Right.
So pain with sex is different than libido, but at the same time, it can definitely make you not want to have sex.
Yes.
Which is part of that. And then just the hormonal changes of, being postpartum and you're breastfeeding, people tend to have very dry vagina. And that can also affect it. And also just the stress and fatigue of lack of sleep, relationship changes that happen. It is complex. I mean,
yes, I have
you see these issues.
Well, and I've got kids, so I do sort of remember what that was like,
Yeah. But I mean, just the dynamics that change in a relationship when you're not sleeping, you're trying to figure out who's doing what and how that affects your intimacy and wanting to have sex. And then just for women, how much fatigue and stress just affect our libido.
Right. And you mentioned diseases that might be going on that would affect libido or arousal.
I mean, I think a lot of mental health diseases. So yeah, depression, things like that. But if people have, even things like back pain and chronic opioid use. I mean, different things like that.
Yeah.
Addiction kind of things. And definitely there's other things that can be contributing in some way. So I think those are important to kind of weed through to make sure there's not something else that needs to be addressed before we jump into trying to treat this with hormones or, other things like that.
And I would imagine the same thing with men, that something like being pre-diabetic or heart disease, those kinds of conditions would also affect sexual response, right? Which could affect libido potentially.
Right. Yeah. And I think definitely, in obesity, things like that. And I also think even just body image, even though it's not really a disease, but, I think about diseases, obesity, and the things that go with it, the heart problems and things like that, but also body image, I think has a big effect on libido.
Yeah. Okay.
Yeah.
So what are some of the medical, the treatment options available for women? I guess pre and postmenopausal, if it's different.
Right. So for premenopausal women, there's a new drug on the market. It was FDA approved back in 2015, fulbanserin or Addyi. So not being, I don't use it all that often, but I don't have a lot of takers for it. But it is a drug that is specifically FDA approved for the treatment of hypoactive sexual desire disorder or low libido in women. Okay. So it is a CNS agent, so a central nervous system agent, similar to an antidepressant. It actually was put on the market when they first started to do trials in this medication. They tried to use it as an antidepressant, and it didn't do very well for that. But people reported increased desire.
Oh my gosh! So it's a similar story to Viagra, right? Designed.
Yeah, exactly.
People are like, oh wait, I like this.
Yeah. So it took a very lengthy process to get it FDA approved for this treatment, and there was a lot of question about whether it really is truly effective or not. But the idea is it's supposed to increase the number of satisfying sexual events per month for a woman and decrease her distress about it, about low desire. Okay. And so some of the controversy about it is that the increased satisfying sexual events, which is the endpoint the FDA made them use, isn't very high. It's like a 0.5 to 1 increased sexual events a month. But for women who aren't having satisfying sexual events, that actually is more than nothing.
Yeah.
And then it was statistically significant that there was a decrease in distress about it, because that's the big thing, is that some women have low desire and they aren't distressed about it. But if they are, and it's affecting their relationship, guilt, embarrassment, all that, then it is actually a really big deal that affects their day-to-day life even.
Yeah.
And so it does show to help that. And so it is a nightly medication that patients can take before they go to bed. There originally was a big alcohol warning with it, that you couldn't drink any alcohol with it. And patients had to sign a document that had to go in their chart, and the pharmacist had to see that they would not take any alcohol with it.
Wow.
But they recently just changed that so that you can have up to 2 servings of alcohol as long as it's as long as you don't take the medication within 2 hours of drinking the alcohol.
Okay.
So in the way they did these studies about the alcohol is they had men, mostly men, drink 4 servings of alcohol in 10 minutes on the medication, and a couple of them passed out. And so the whole idea was that they were really worried that women were going to drink alcohol and pass out or have really low blood pressure when no one gets up in the morning and drinks. Well, hopefully most people don't get up in the morning and drink 4 servings of alcohol.
Not in 10 minutes, at least,
right.
Especially.
Exactly.
And then how do you, I know that part of the controversy around a medication like this for women is the idea that women's libido is sort of broken, or it's as simple as a pill, like how do you determine when you would prescribe something like that versus realizing, it's sort of systemic and there's a lot more going on?
Right. I think there's always more going on. I don't think this is, I don't think there's just, I don't think there's ever going to be just a women's Viagra, because our sex drive is so much more complex. There's so many factors, I feel like. So I always talk to them about women's sexual response and what's normal and how our desire is different, like spontaneous versus responsive desire. I talk about, the idea of our sexual control center and our accelerator and our brake. These things that, I think make a big difference in how we think of sex as women. Yeah. And so I think I don't think that this pill is just going to fix everything. Right. But I think that some women come in and they're so distressed about their low desire, or it's affecting their relationship so much that they are just like, I need something. Yeah. And you sex therapists are lovely, but you're not always, sometimes it takes a while to work through some of those things. And so I think some people just want to try something right away. And I think as long as they understand the risks, I think it's worth a try. Okay. But I definitely think it often goes hand in hand with some behavioral changes, some sex therapy, some, couples counseling, things like that. Because I don't think it's just the end all be all, like take this, it's going to fix everything. Right.
Okay. And what about treatment options once somebody's in menopause?
So that medication is not FDA approved for the treatment of women after menopause, although there are studies that show that it could be effective. So sometimes I use off-label testosterone. So a lot of studies out there that testosterone for postmenopausal women can increase sex drive. So I use it off-label. It is a topical that they would rub in, like in their armpit or on their inner thigh somewhere, and they can use it daily, and it can slightly increase testosterone levels that should hopefully increase their libido a little bit. Okay. It probably will never be FDA approved, even though it's very effective, just because long story about the FDA not really being very easy to work with on these medications for women's sexual dysfunction, unfortunately.
I can't imagine why that's not a priority for them.
Right. I think there was a company that tried to get testosterone to market for postmenopausal women, and they went bankrupt trying to do it because the studies were taking so long and there were so many things the FDA was making them do. So I think no one's going to go back to testosterone, try to get it FDA approved, but we can use it off-label and like compounded or at a 1/10 of a men's dose of testosterone.
Okay. And are there, I'm imagining cancer risk and things like that would be maybe a counterindicated, what's the word?
Contraindication.
Contraindicated. I can't not get that to come out of my mouth today.
We wonder about the cardiovascular risks, but the studies don't show that they greatly increases cardiovascular risks. Again, we don't want to raise the level very much. And so I do actually follow their testosterone levels. Like I don't want them to get to men's level of testosterone.
Well, no, I
want to keep it, or even close to that. So, So I do follow their levels pretty closely and make sure they stay fairly low. But we think the risks are actually fairly low for both cancer and cardiovascular disease with it.
Okay. And then is like hormone replacement therapy, does that have anything to do with libido, or is that purely about hot flashes and vaginal dryness?
It is mostly about hot flashes and vaginal dryness, but I think that when you don't have hot flashes and you sleep better and you don't have vaginal dryness and can't have sex, you want to have sex more, right?
Right. So you see how all this stuff is intertwined. Yeah. Okay.
It is. It's like I said, that's why there's probably never going to be the one thing that fixes it all. It's like you have to look at the whole picture. And I think all those things make a difference.
Yeah. Okay. And as we wrap up the low libido part of this conversation, is there anything that you would say about when somebody might want to see their physician about a concern about libido versus a therapist or a friend or when would they maybe consult their doctor?
Right. I think if it's becoming something that's affecting their life, I think any of those people can help them, but I think that coming at it from multiple angles is probably the most helpful. And so having, seeing a sex therapist, seeing, a physician that could talk about hormonal treatments or, fulbancerin, something like that, I think it's important at least women know their options and know that there are ways to make this better, even though it may not be one thing that fixes it all, but multiple aspects of her life could be looked at and things could improve.
Right. Yeah, with the caveat that their doctor may not, have the awareness and training that you've got. So people might need to look around or something.
Yeah. And there's not a lot of us, but there definitely are people who are kind of specializing in women's sexual health. And I do think it's a really important part of women's health. And
I know.
It's worth our time. And women are worth this conversation because it affects our relationships and our lives and how we feel about ourselves. It's really important. So
Right.
Yeah.
Hey everybody, it's Jessa, and we're just taking a little break in the show so I can share something exciting with you. At least I think it's exciting. I wrote a book called Sex Without Stress, and I had turned it into an online course, and now I've reformatted it so that you can sign up at any time. It's more like an a la carte thing. For less than $100, you and your partner can work through this entire process, guided through webinars and assignments and conversations to have and real-world exercises to use to take the stress out of your sex life. So if you're in a good relationship but sex is the issue, this could be a perfect fit. And then separate from that, you can opt into my membership group, month at a time, or you can sign up for a whole year. That's where you'll get the personal support while you're working through the process. So it comes with Q&A sessions, bonus content, some guest presenters, and a private support community like a forum. So that's priced separately so you can just participate in that when it's useful to you. Anyway, if you want to learn more, go to sexwithoutstress.com. And now back to the show. All right. So in the sexual pain arena, it's such a big topic, right? Because there can be so many different things going on. And I can't remember the stats right now, but I know it's a huge percentage of women that are going to have pain with sex at some point in their life.
Yeah, like 65-70% of women have had pain with sex at some point in their life. Maybe not all the time, but there's some women that have had pain with sex their whole lives.
Yes.
People just have pain with sex for certain parts of their lives, but it is really, really common.
Okay, so what are some of the things that can be causing that pain?
Yeah. So, this is where we talk about the vulva and the vagina being a little bit different. And
right.
so, I kind of...
Do you want to define those for the listeners?
So the vulva is really more the outsides, your labia, where the hair goes, labia majora, and the smaller lips, the labia minora. And even that transition from the vulva to the vagina right before the hymen is called the vestibule of the vagina. And that's where I see a lot of women have a lot of pain. And so for a lot of women, this is where penetration pain occurs, like with insertion for intercourse. But that's where I see women have a lot of pain, is right at that vestibule or the opening of the vagina.
Yeah.
And then some women also will have pain deeper in, like pelvic pain, more with deeper penetration. And so very different etiologies of those pains.
Right.
And so when I have them come in, I kind of try to figure out when they feel it, what positions or what sexual acts make it worse.
Right.
Is it all the time? Is it sometimes? What things have helped it? What things have made it worse? Those kind of things.
Yeah. Okay. And I guess even get them to describe the type of pain they're feeling, right? Burning,
snapping, exactly.
Throbbing, whatever it is. Okay.
Exactly. Is it burning? Is it sharp? Does it radiate somewhere else? Like just kind of I feel like I'm a detective trying to figure out exactly when it's happening, and in my head thinking about what is the mechanism physiologically of what's occurring.
All right. So what are some of the explanations, medical explanations for these various kinds of pain that people might have?
Right. So some of the pelvic pain that women have and some of the deeper penetration pain, I think can be from tight muscles in the pelvic floor. So our pelvis is so complex. We have so many muscles that hold our whole bodies up and help our core. And these muscles can be affected by childbirth. They can be affected by just being pregnant. They can be affected just from a back injury, a hip injury, different things like that. And I think that our bodies change in response to pain. So if we have a certain pain that's, certain pains in our body, our pelvis may tense up in preparation, in reaction to that pain. So I definitely, when patients come in, I do a really good pelvic floor exam where I'm actually feeling the muscles of their pelvis to evaluate where this pain could be and try to figure out how they could be helped, potentially by pelvic floor physical therapy, which is, going to see a physical therapist that helps teach them how to relax that pelvis and help work out some of those muscles that might be tight and might be contributing to that pain.
Right. Okay.
Yeah. And then I sometimes show them, I don't know if you've heard about the O-nut. Have you heard about that?
I have heard of that, yes.
Yeah, so I figured you had, but I'll show patients that if they have deep pain with penetration. It is a penile ring that is like almost like a foam type texture, and they're stackable, and it helps decrease the depth of penetration during intercourse, and can be. The hope is it reverberates some of that. Reverberate some of the pressure back to the male partner instead of always to the woman, where if her pelvis is sore. So it's great for people with deep, like endometriosis type pain, that kind of pain, or this muscular pain.
Okay. And is there for somebody that might have endometriosis, or even something like pelvic inflammatory disease or something, right? Because that can also cause that deep pain.
Exactly.
Are there treatment options for that, or is that something they just need to sort of accommodate with an O-nut or different types of sexual practices?
Right, exactly. I mean, so endometriosis, there are definitely treatments for it. And I definitely see a lot of patients that I medically manage for endometriosis. Sometimes they need surgery, but a lot of times we can try to help with medications. There's actually a new medication on the market now recently also for treatment of pelvic pain for endometriosis, and actually has really good look at the painful sex with endometriosis. It's called Oralisa, and it's similar to a medication that we use a lot for endometriosis that for a long time that puts people into temporary menopause, called Lupron, but it's an injection that has tons of side effects and it lasts a long time. Okay. And so this is a similar type medication, but it's a pill. So if you don't like the way it makes you feel, you can stop taking it, which is much more beneficial than a long-acting injection.
Right.
And it has way less side effects, so way less of the hot flashes and vaginal dryness, which is really helpful. But it helps in studies. It decreased pain with periods, pain in between periods, and pain with sex in women who had endometriosis.
Oh, okay. So that's a nice development.
Yeah. And I think too, that I see a lot of sexual pain patients, and I'm sure you see a lot of sexual pain patients also, but there's a big psychological factor. And I always tell patients, I don't mean that they're making up their pain, but I think our bodies change in response to pain, and our psychology changes in response to pain. Yeah. And so when we expect something to hurt, our automatic intuition is to tense up. So that tenses up our pelvic muscles. And I think our bodies learn over time if we're continuing to have pain in our pelvis, to continually be tighter and tighter in our pelvis.
Right.
And so it's always kind of hard to figure out. People may have endometriosis, but they also have pelvic floor dysfunction. It's not sure what happened first, but they kind of all go together because it's a reaction to something.
Right. And I certainly have clients who have, vaginismus, which for the listeners is such tightness of the pelvic floor that it might prevent penetration, right? And that's painful. And so sometimes that's in response to some other painful condition, but that could be the beginning out of fear or trauma. Like I'll see clients that haven't had some other pain condition, but have still developed this sort of involuntary clenching, reaction.
Right. And I think the more they have the painful sex, the more it gets into this kind of cycle of kind of catastrophizing over how it's going to hurt, and it does hurt. And so one of the things I always tell my patients is like, let's try to get things better before you continue having painful sex. Because I don't want their brains to learn that this is how it's going to be, and then expect it, and then contribute to it in some way, because the body's kind of preparing for that pain.
Yes. Yeah. I certainly tell people, don't do things that hurt.
Yeah, exactly.
Counterproductive. It's just digging yourself in deeper. Yeah.
Yes.
And what about, the very broad category of vulvodynia, which means pain in the vulva region?
Right. So pain in the vulva region. So vulvodynia is I find to be really interesting, but also really challenging to treat.
Yes.
So I see a lot of patients with vulvodynia, and it can be something that women have had for just a short period of time, or something they've had for their whole lives. Okay. And it can be anywhere in the vulva. But as I mentioned earlier, I see a lot of women that have it at the vestibule, or right at the opening of the vagina. And it can be for so many different reasons. Sometimes I see patients who have it for hormonal reasons. Some of menopause hormonal changes put pain there, but also women on birth control pills who have low testosterone levels sometimes have a lot of pain right there. I actually see that not infrequently. Okay. And then sometimes it can be inflammatory in nature. So, we kind of think that there's somehow some women will have multiple yeast infections, and then it sets off some kind of abnormal immune cascade that creates basically an overactive immune response in those cells right there. So even light touch causes tons of inflammation, and Even a small amount of yeast that may not even be clinically significant on a test can cause tons of itching and irritation and burning.
Wow.
And so we don't understand these things. I think there's a lot of research being done on this right now. But those are two of the things I see probably the most. Although there are other things that could be causing it, like vulvar dermatology things,
right?
And then also pelvic floor. That tight pelvic floor we talked about before with the vaginismus also can actually get out and affect that opening of the vagina and the vulva too.
Right. So what are, and again, you sort of listed a broad array of things that might be hurting there, but what are some of the treatment options for people? Is this hopeless?
No, it's not hopeless. I think it's difficult for patients for sure, but I also think it's difficult for clinicians because it's not always this one obvious thing that's going to be the one thing that helps them. So I usually tell them at their first visit, because they've usually seen multiple providers before they've seen me and made it better. I tell them I will always listen to them and believe them, and we will always try something else, but there's probably not one magic thing that someone's been withholding from them that will be the end all be all thing.
Okay.
And so sometimes it's trying different things. So I sometimes check their hormones and look at their testosterone levels, if they're on birth control pills. If it's hormonal, I sometimes give them a topical estrogen testosterone to help with that if I think it's a hormonal pain.
Okay.
Sometimes I use steroids if it's really inflammatory, and they'll sometimes work, but usually not enough.
Okay.
Sometimes I've talked to them about actually injections of steroids and numbing medication like lidocaine and steroids. Sometimes can give them longer term help. Sometimes I use topical or oral neurogenic pain medication. So gabapentin is a medication for neurogenic pain. Because I think the idea too is that their nervous system starts to learn that touch there is painful. And so even though there's not a painful touch, their body's interpreted as that. And so it makes sense that this medication that's basically a pain for, like a lot of diabetics, patients use it for neuropathy, so neuropathic pain, is that topically or even orally can help decrease the way the brain's interpreting that as pain.
Wow.
So some of those are the kind of things that I start with, although I have a large array of options my arsenal that I try to use, but I always tell the patient we may have to try multiple things before we're really at a place where things are all the way better. And it may mean, we may not get all the way better right away. It may take a while.
Yeah. And what about surgery? Because I know that exists, right? And I would imagine that's a last resort kind of.
It is a last resort. So there is a thing called a vulvar vestibulectomy, where you actually remove that small layer of tissue between the hymen and the opening and the vulva. And for women who've had this their entire life and nothing has worked, or women who have acquired this from, we don't really understand why, and I've kind of gone through everything, it is something that can be really helpful. It is. I don't think it's done very often. I don't do it very often, but it is something that I think I've met women who have really, really done well with it.
Okay. Interesting.
Yeah.
I'm so glad you're doing this work. I'm so glad to have connected with you in Seattle and have you to refer to, because it's just so hard to find physicians really well versed in this, who are prepared to, to, like you're talking about, walk a long path with women sometimes.
Right. I mean, I love it because when I do, I think some clinicians are scared to take this on because it's hard, and it is hard. But when I see these patients come back and all of a sudden something we tried is better, I get so excited. It just makes me so excited that I'm doing this work, because these are women that have been bounced around from physician to physician and, feel like they've been brushed off and feel like the medical community has failed them, because this is part of women's health and it is part of our basic physiology to have sex. And when these women can't have sex, then it's a huge impact on their lives and their relationships.
Yeah. Well, of course, I'm in the work for the exact same reason, right?
Exactly.
It's a quality of life issue, and I want to help.
For sure.
So where could people learn just a little bit more about you? I don't know if you've got your own website, or if they wanted to get in touch, how would they do that?
Yeah, so I'm on the Swedish website, just search under providers, and I have a information page about me on there. And then they can always call my clinic. I don't have a private page or anything like that, but they can always call my clinic and get appointments with me or ask my scheduler about different types of patients I see. But I'm very open to see a lot of sexual health complaints. Okay. And I do basic gynecology also. So if there's gynecologic things going on, I also do that.
You can help with that too, right?
Exactly.
Yeah.
And then I also have a couple blog posts about sexual health that are up on the Swedish website about sex after baby, about low desire, like we were talking about. And I have a whole article about when to talk to your doctor about sex. So it's one of the things you might mention earlier.
Perfect. Too. Okay, great. I'll make sure that those links are in the show notes too, so that we
love
got that covered. So
yeah.
Well, thank you so much for taking the time to talk to me today.
Thank you so much for having me. I really, really appreciate it. It was lovely talking to you.
You've been listening to Better Sex. Please visit our website, bettersexpodcast.com, for show notes and additional episodes.
And that's a wrap for today. I really hope you enjoyed the episode. If you are enjoying the podcast, if some of this material resonates with you and you would like to make a difference and make sure that this keeps coming out in the world once a week, ongoing, there are a couple things you could do to show your appreciation. The first would be to go to iTunes and rate and review the show. That really helps us be found by new listeners when you review the show on iTunes. You can find a link at bettersexpodcast.com/iTunes. The other thing I want to invite you to consider is becoming a Patreon. For a small monthly pledge, you get some benefits. So for $2 a month, you get advance access to every single episode. For $5 a month, you get a chapter of my upcoming new book. And for $10 a month, I host quarterly get-to-know-you and question-and-answer chats over the web, and you get invited to that. I would love to have your membership in that, become part of the Better Sex family. You can find a link at bettersexpodcast.com/Patreon, which is Patreon. Again, thanks for listening. I'm glad you're here. Feel free to comment, ask questions, get in touch. I'd love to hear from listeners. Thanks.